The next session will be Dr. Venkat Sai V from Queen's NRI Hospital, Vishakhapatnam, and Dr. Arun KN from Bhagwan Mahavi Jain Hospital, Bengaluru. And the speaker is Dr. Feroz Aziz. The topic will be on overcoming the HLA barrier challenges in paired kidney transplantation.
I think it's not an easy task to be between you and the speaker just before the pre-lunch session. So I think we're going to make it very informative and productive. The topic chosen for today is to cross the HLA barrier across the current environment in which we practice. So no better person than Dr. Feroz Aziz, who's very well trained in this arena of HLA immunobiology. He had his formal training in the HLA immunobiology in US. And then he's also a practicing senior transplant nephrologist. He works in ICRA Hospital, Calicut. So without taking much time, I invite Dr. Feroz to deliver the lecture. Thank you, Feroz.
Respected Chair, teachers and friends. On behalf of my team, I thank the organizers for giving me this opportunity. For the next few minutes, I'll be taking your time to discuss how we can facilitate a paired kidney transplant through the eyes of a HLA lab. So this is the first paper actually that stated paired kidney transplant is possible. It came from Korea way back in 1999. Of the 61 transplants they did at that time, few transplants were to facilitate a better HLA match. So this was much before our understanding of current day antibodies. So basically paired kidney can actually, take us across the highly immunological ABO barrier as well as the highly polymorphic HLA barrier. So, but only few centers are undertaking this exercise, but the encouraging thing for us is that more and more national programs are coming up. So what are the options in front of our sensitized patient? Either a deceased donor that is compatible or a paired donor or desensitization. But the drivers of this decision making involves many other things. It depends on the dynamics of your deceased donor program, how good is your dialysis backup, how is this breadth of sensitization, and the network and the donor pool that we have. So our strategy is going to be population specific. So in North Kerala, where I come from, we have 6 districts out of the 14 districts of Kerala, where population of more than 1/3 of Kerala. We have a big, broad-based dialysis centers, and we have a lot of transplant patients converging to our area for transplant. So we needed to have a program that is designed for our area. So first thing that had to think is that we have to talk with the patient. From an HLA perspective, you have to describe that you are sensitized. The probability of you getting a transplant is so much. So that have to have some sort of a objective criteria. So that was the first question. So the definition of sensitization has evolved over the years. Currently, what is happening in Western world is that they have a database of like 12,000 HLA, deceased donor HLA, and they compare the antibody profile against that HLA pool. So we wanted to start a local PRA calculator. So for that, we took the 712 donors in the last 10 years with ABA DRN typing, and one of our young nephrology colleagues who was tech savvy, who sat and he built up this same PRA calculator tailored to the Malabar, North Kerala region. So basically it is converted into an Android app. We just put the unacceptable antigens of the antibodies there, and it gives you the PRA value. So this is actually, so the interesting thing was that when we compared it with the already available Western PRA calculators, it is differing by at least 10 to 30%. So we were a little more comfortable in discussing this with our patients. So this is the spread. So far, almost 52 patients have been through our paired kidney program, and of which almost 50% of the patients are having a calculated PRA of more than 80. So we are dealing with pretty much sensitized subgroup in this program. So second is the donor pool. So the donor pool, actually, the patients who are going to stay in your pool is the first one, the sensitized patients with incompatible donors. Then you have the ABO incompatible players. And most importantly, those small in number, they are the facilitators. There are a subset of facilitators who might have some benefit, like they might get an age-matched kidney, but at the same time, there are facilitators who are totally selfless. We request the donors to be at least in the pool for at least 2 months so that we can have some meaningful runs. Coming to the facilitators, I think we have, as nephrologists, we have an important role to play. We have to be very sure that the facilitator is not at any disadvantage. From some, we have, donors willing to pair, but they have a DR matched donor. We have facilitators who have come, but the kidney, they are going to get multiple vessels. So that I think there the responsibility stops at a nephrologist's table. Then the crux of today's talk is the histocompatibility testing. Let me, just like a disclaimer, I would like to say that, the whole histocompatibility finally converges to good decision based on knowledge. It is not run by numbers. So one fundamental point is that we have to fix that flow cross-match is going to be your final gatekeeper. It is sensitive, but more than sensitivity and everything, what I find is that it is objective, When you have a centralized lab, you can show this is how your results are, and it is some sort of a semi-quantitative. So this is one patient who had been run against multiple donors at multiple time points. We have a linear flow scale where 50 is the T cell cutoff and 100 is the B cell cutoff. So we can see, of these donors, we can just profile the donors and see that this is, T and B negative, this is only B positive. So this profiling helps in flow cross matches. The second thing is how to interpret the single antigen bead readout. Nowadays you are seeing a lot of readouts. So analyzing a single antigen bead. So single antigen bead is basically it's a good tool. It's a very sensitive test, but it is infested with a lot of limitations. MFI is not tighter, and the take-home message that I would like to discuss through this talk is the pattern. Now we have to familiarize with the pattern rather than the MFIs. And again, your final gatekeeper is going to be your flow cross-match. So regarding how to analyze SAB analysis, SAB readout is that first you should have the recipient and donor typing. You don't develop antibodies against your own HLA. Suppose you have an antibody, the antibodies, the bead should be at the tail end of the graph. Suppose you have a high-rising antibody in a very high MFI against your self-antigen, that means it is wrong. You have to ignore that. It might be that particular bead has some cryptic antigen eliciting that response. Second is cutoffs. So it is primarily vendor-driven, pretty much standard. It's A, B, DR, and DQ. You have a cutoff around 1,000 to 2,000. But coming to C and DP and beads, they are super saturated. The recombinant HLA, everything is man-made, right? So the recombinant HLA that is stuck down to these beads are like higher than physiological amounts. So you have to keep a cutoff a little higher, like 2,000 and 3,000. But when you get a super sensitized patient with a PRA more than 80, your cutoff like 1,000, 2,000 is not working. You have programs where they have get cutoffs like 7,000 and 5,000, so that our ultimate aim as a clinician is to facilitate a transplant, not to deny one. Now, the pattern. So this is again the second core area which I would like to highlight. You develop an antibody against an epitope. Epitope can be seen across many antigens, okay? And these antigens are what you are seeing in the beads. So we should familiarize with these patterns. So the group of antigens against which you cross-react or they share the same epitopes are called the cross-reactive groups. Don't get upset by this graph. We'll make it simple. The most understood illustrated Craig groups are the A, B. And the A, this is the one you see in the big rectangle column is one big Craig group, okay? So in that you can see different numbers. There are some small Craig groups, and between, you see in the A2 Craig, you see 57 and 58 bound by a dark band, line. So that means, they are very closely interlinked. When you develop an antibody against B57, it is almost 100% likely to cross-react with B58. So that is very important. Then you have HLA B Craig, there are more Craigs in B. So this is, suppose you get an antibody like this, you're just a high-rise building standing in the middle of the road. But we analyze into a Craig pattern, what we see is that everything is falling into A2 Craig. For this patient, you have to have a donor out. This is correct, simple, okay? And another important correct pattern is the BW4W6 pattern. All the HLA-Bs with some A's and some C's will have either a BW4 epitope or a BW6 epitope. That means you have either one jersey or another jersey, just like a football ground, okay? And unfortunately, if the patient develops an antibody against a BW4 epitope, all the antigens that come under the BW4 umbrella will be hostile. So to facilitate a donor, if you have a BW4 epitope, you should go outside that group. For example, we had a patient who was sensitized, husband was the donor. This was the SAB report. So we'll zoom in. So what we see is all of this BW4 subgroup of cross-reactive antigens. So how to facilitate a donor? So in the lower end, you have the antibodies, that is the BW4 correct, and you have 20 donors. So what you do is that you cannot have a donor with BW4. So you have to have a donor who is homozygous to BW6. Now the search comes down to 9 or 10, okay? Now you look for your age, now you look for your blood group, now you look for other donor-specific antibodies. This is how you narrow down in paired kidney transplant. And you have, at the end of the day, again, you have to do a flow cross-match, which should be reassuring. And this is BW6 correct. Here what I would like to highlight is, many times we don't look at C, we look at B and say that the MFI is low. So this is, when a particular run was done on that day, we got this pattern. But the pattern is very important. You are having a donor-specific antibody with a MFI less than 1,000. You should not, I mean, we should not see in that way. You should zoom out and look. You have a pattern which is BW6. And if your cross-match is having some nuisance, you have to avoid that BW6, go for a BW4 donor to facilitate a transplant. So this is the importance of having a pattern. Now, HLA-C and DP, I alluded a bit. Basically, they are overexpressed beads. So the thing is that you have to give some sort of allowance for that. But again, HLA-C, there are two classical epitope patterns. So usually you don't see C in isolation. C comes as a group, okay? It comes as either one of these two epitope patterns. And coming to DP antibodies, you have 5 classical patterns, okay? This is one of our patients who was sensitized, class 2 SAB. What we did was that, you see, so when we look, it is all DP. So just write down, sit with a full A4 size paper, write down these DP antibodies. These are the DP antibodies. Compare with the correct chart, everything is falling into 84 DR correct. So if the cross-match is positive, you have to find a donor outside this group to facilitate a transplant. So, so what is the take home from correct point? So if you have a cross-match issue with the identified correct, you have to go outside the correct. Otherwise, you are not going to get a donor. But there are two different schools of thought. Some people, even they avoid a correct if it is cross-match negative. That is very center-specific, and there are two schools of thought. And now tackling the DR and DQ antibodies, this is the most challenging part, okay? So that we have to stick to some fundamental principles here. DR mismatches, we all know that it has got a very strong influence on allograft survival. And DQ, the interesting thing with DQ is that for one DR, a DQ is fixed. They both go pair and pair, okay? So DQ correlates with DR. And as we all know, there are a lot of evidence accruing now. If you have DQ donor-specific antibodies, that is going to be not good in the long run. And this is the associations. You can just Google it and get it. And coming to A and B mismatches, the issue is that if it is not alloreactive, if your cross-match is clean, then AB mismatches does not have, it belongs to a benign end of the spectrum. It's not that bad like you're having a DR or a DQ. So I'll go run through a patient. So this is a 44-year-old male who came for a second transplant. First was mother, lasted for 15 years, came with sister was cross-match positive. Okay, so initially we do a screen, the screen class 1, class 2 positive, and we did a SAP. So still we do manually. So this is on the right corner, you see the blue block. So that is the patient's, a lot of antibodies in A, B, and DR. And in our calculator, he had a CPR of more than 95. And the yellow line at the bottom is the patient's self-HLA. Now you have all this, you have 38 donors. I've hidden some so as to fit into the slide, okay? Now you cannot fix all these things. So what we look is that try to fix DR. So my aim is to find a donor who has 0 mismatch in DR. So I find 3 donors. So my search has come down from 38 to 3. Now things are a little more easy for me right now. Out of those 3, now I'm going to look for my class 1. Unfortunately, he had DSAs against all the 3 donors in class 1. So what can be done? We do a cross match. So the cross match is, luckily, one patient was cross match negative. Okay? So this is, I will show it in a different way. So this was his single antigen bead layout. Okay? The one graph, 11,000 MFI, B57, own sister, cross match positive for T and B. Then luckily this donor A3 against A3, 5,000 MFI, cross match was luckily negative. Again, you have a donor with a lesser MFI and cross match was positive. This is where I told our fundamental concept should be the alloreactivity based on a flow cross match. And we had to again reconfirm by flow cytometry cross matches. The thing is that you have to do a lot of surrogate cross matches. Just by one negativity you cannot go. You have to tease out, take donors from your, take people with non-HLAs from your pool, might be all recipients. You have to rework this and finally narrow down in a super sensitized patient. Okay, and we actually did just like any higher risk transplant with induction and all. So the fundamental approach is go for a zero mismatch in DR. So automatically DQ follows DR. So we are done with that. Now try to find your compatible donor based on your class 1 reactivity and your age and all other things. Okay, a lot of surrogate cross matches are often needed. So to conclude, your paired kidney program can jump both these barriers. So bigger the pool, donor pool, more options you have. Flow cross match should be the gatekeeper. Single antigen analysis, I think as clinicians, we should start looking at the patterns. And need of the hour on such societies is that we should do a lot of networking. And in the enthusiasm of doing more paired kidney transplant, I think we should be very clear that we should be within the Lakshman Rekha of ethical framework. This is the data. We had 108 transplants done. We did inter-hospitals, 12 patients where the donor used to travel. ABO incompatible, almost the same number. And this is a deceased donor transplant in 75. And the thing is that, the deceased donor program got a rough patch in Kerala. And I wonder if the disease program had been thriving, whether we would have ventured into ABO or paired kidney. I don't know. And why people came to PKD, still it is to avoid ABO incompatibility. Okay? And you see in the last few years, more and more sensitized patients are coming up and accruing. And if you superimpose ABO incompatible onto this thing, still ABO rides high because almost majority of our donors, like in any other transplant center, are parents or siblings. So we are forced to give them an advantage of HLA. We do that talking, and so ABO still runs much higher than the number of paired kidneys that we do. And coming to the sensitization, so this is it. We are doing a reasonable job till PRA of 80. Beyond PR of 80, we are still, I think more networking between us is needed. I represent a big team. I personally thank my mentors and my transplant immunology coordinators and lab people, the unsung heroes, and my colleagues from whom I learn every day, and above all, our patients. Thank you.
That was really wonderful, sir.
Thank you for your lucid presentation and a hands-on experience in dealing with a great problem we face day in and day out. The sensitized donor have to start with, they get frustrated, then they even start fighting with us many a time, and the problems we face when we send them for a cross match every time a cadaver comes up is also many a times we have seen this happen, and they try to bring in politics also, saying that they are being denied because of various reasons. A paired kidney donation has started off with ABO incompatibility, and I think ABO still scores over HLA as far as the overall outcomes are concerned. I'm really happy that you have started your own mapping, and you are collecting data for the HLA mapping for a huge region, and hopefully if we get more data on this, I'm sure we'll have better ways of doing a virtual cross match also, where we can have better outcomes even in sensitized patients. So I open the floor for discussion.
One comment what you said that if the PRA is more than 80, you can go with MM5 of 3000. Now, for a clinician, the biggest issue is that one practical approach is that suppose you do transplant with that MFI, what are the chances of hyperacute rejection? We know that they can have a long-term graft survival which can be poorer, but that is sometimes it is acceptable, but the hyperacute rejection is not acceptable. So are there chances of hyperacute rejection in that scenario? What is your educated guess?
So with a flow cross match, so I think the final gatekeeper is still the flow cross match. It's not the MFI, okay?
Well, in
So
disease donor, I'm sorry.
if a flow cross match is negative, so with a DSA and with a flow cross match positivity, it is a big no, as of now, okay?
No, flow in disease donor, we are generally doing DSA and flow will take more time to get the report. So in disease donors, because in our center is Hyderabad is now going towards more disease donor transplant.
Okay.
So what to do in disease donors?
Okay, so what I would say is that this is where the surrogate cross matches come into place. You have a patient waiting in the deceased donor. You know that he has got so many antibodies, okay? So what you can do is that you have, all these HLAs are amidst us, So you find surrogates having these three, and you try to do surrogate cross matches, and you can be sure that though he has a DSA, he is flow negative. So in the middle of the night, so we do, so for our heart transplants, when they have antibodies, we do surrogate cross matches and we profile them and keep them. So surrogate cross match should be the way forward in your case. That's my suggestion.
So if the flow is positive, then there are more chances of hyperacute rejection in this scenario, I mean to say.
Okay, with the current evidence, we can say that there is increased chance of rejection, definitely with flow positivity, but hyperacute, I would say CDC is positive, then only you will have hyperacute. Otherwise, I don't think that I have never seen a hyperacute with a reasonable flows at least. I have not dealt with very high flows. If T and B is positive, I don't have the courage to transplant them.
Okay.
Dr. Feroz, first of all, much appreciated that you finished your talk well ahead of time, short, crisp, and sweet. Just two observations. You said about the DP, basically, and when you said you have a DP mismatch, SAP positive, would you still go ahead with the transplant, or would you hesitate to do a transplant, considering the fact that the DP antigen representation in the renal endothelium is almost negligible? Yeah. And most people, at least I don't give a lot of importance to the DP. So just wanted to know your thoughts from your experience.
Coming to DPs, in all the cases, I have just dealt two DPs which have created problem. In one DP, we could gem it, and other DP, I'm stuck. This is my experience with DP, okay? But my personal take is that if your cross match is really clean, then to gem a DP is quite difficult. That's why I'm stuck with the second case. You have and many of the DPs we don't know. That's another thing. So I think with the available evidence, if your flow is negative, then, and if it is, if you don't get another donor outside the DP, I will just go ahead with that's it.
With those thoughts, I think quick observations. In the market-driven economy, there are fee-for-service labs, and there are labs which think. So to answer Dr. Saha's question about hyperacute rejections and all, you get a number in the middle of the night. And most of the residents don't have enough HLA exposure during the training, and they're not expected to know. It's a very niche field and an experience. So we require a resource person, like Dr. Feroz and many more people, to have a hotline to contact on the night. Yeah, okay. So otherwise, it's not going to be an easy job. We might be inadvertently saying no to a potentially transplantable case, or be hyper cautious, and then get a lot of anxiety in the middle of the night. So be aware of the fee-for-service labs which are there in rampant. The techniques they do and give you a number is not validated in the HLA world. This comes from a personal experience, both from the West and from India. Thank you.
Thank you, sir. May I now request the chairperson to honor Dr. Feroz.
After this session, we will break for lunch, which is provided in the back hall. So those are not connected to delegate bags. Short lunch break of 20-25 minutes.